Welcome to our operating theater, and thank you for joining us for arthroscopic debridement of arthritic elbow. This is the case of 32-year-old male who sustained radial head fracture 4 years ago, and since that time started complaining on elbow pain, mostly at extremes of motion, later also limitation of extension and recurrent locking of the elbow. On examination, there is a slight limitation of extension and painful limits of motion. CT scan reveals secondary arthritic changes. Multiple loose bodies, olecranon and coronoid osteophytes, slight deformity of radial head with secondary degenerative changes. Patient is placed in supine position under brachial plexus block. Arm rests on narrow anesthetic support. Tourniquet is on. Shoulder is at the level of the support. This allows for access to lateral, posterior, and medial aspect of the elbow. Before starting the procedure, anatomic landmarks should be outlined, including radial head, lateral epicondyle and olecranon on lateral sides, and medial epicondyle, olecranon, and ulnar nerve medially. Next, needle is injected through the soft spots and capsule expanded with 10 to 20 milliliters of saline. This pushes the radial nerve away from the entry point laterally. After superficial stab incision, scope is inserted via mid-lateral portal. Elbow is flexed to 90 degrees flexion and full pronation. Flexion and pronation moves radial nerve away from the joint capsule, leaving more space for safe entry. Multiple loose bodies are the first items to see after entry. Next, medial portal is established to introduce the shaver. Scope with trocar pierces medially from inside out. Then shaver is inserted into camera sheath and dismantled in controlled way in the middle of anterior compartment. In that way, both median and ulnar nerves are safe. After preliminary debridement of inflamed synovial tissue, loose bodies need to be removed with graspers. Larger loose bodies might need to be removed in pieces, or skin incision has to be enlarged for successful removal. Once anterior compartment has been cleared and working space is prepared, olecranon osteophyte can be resected using osteotomy, bone burr, followed by shaver or rasp. Then, scope is switched with the shaver and introduced from the medial portal. Remaining loose bodies are removed. All parts of the joint had to be explored in search of them. While anterior capsule is released or debrided, care has to be taken not to face the shaver up towards the capsule to avoid damaging the radial nerve. Keep the shaver towards the bone or side without the suction attached. Anterior capsule is released first laterally from humeral attachment, then medially. Tissue elevator can be inserted from proximal lateral portal to expose anterior medial capsule and continue release. Two parallel posterolateral portals are created between lateral margin of the triceps and the humerus. More proximal is dedicated for the scope, and more distal one is located at olecranon fossa and commonly used for the shaver. Once the inflammatory tissues and capsule are partially removed and working space is created, more loose bodies can be found. Both scope and shaver need to be kept away from the ulnar nerve, not crossing posteromedial capsule and staying within the medial gutter. After exposing the olecranon tip, the osteophyte is resected using both osteotomy, bone cutter, and the shaver. Full extension is slightly enforced to seek for any remaining impingement against olecranon fossa. Both medial and lateral gutters need to be explored in search for loose bodies or inflamed tissues. For lateral gutter, scope is moved to more distal posterolateral portal and soft spot portal is created following the needle identification. With the soft tissue shaver, posterior aspect of radiocapitellar and radioulnar joints are exposed. Often, degenerate and inflamed posterolateral pica needs to be resected. Finally, semi-loose bodies found in radiocapitellar joints and resected in pieces. At the end of arthroscopy, range of motion is assessed to confirm full restoration. Postoperative regimen is important in every case. Pain is usually controlled with brachial plexus block. Most of the patients receive tranexamic acid at the end of procedure for bleeding control. Arm is wrapped with compressive dressing and elevated. Indomethacin is prescribed routinely and range of motion exercises are started early both actively and passively. Thank you for watching. We hope that you have enjoyed the arthroscopic procedure with us.